wanted to welcome everyone to Ethics Grand Rounds. I am Julie Swaney, one of the co-chairs of the Ethics Committee at University of Colorado Hospital, and certainly want to welcome you this month to our topic that will be, I think, very compelling by Dr. Furfari. Also wanted to mention before we get going that our next ethics grand rounds will be March the 10th, and that will be on patients with suicide attempts and MAID, and that will be by Dr. Jonathan Treem. So a month from today will be that topic. But for today, certainly want to introduce you to Dr. Kristen Furfari. Dr. Furfari is an associate professor of hospital medicine, and she's the co-medical director of the University of Colorado Hospital at or UC Health Ethics Consult Service. She is going to speak today on From Law to Epic Pathway, and this has been about a 6-year process, the Colorado Physician Proxy law, and give us some insight into how that has been working and the developments there. So, Dr. Furfari.
Thanks, Julie. Thank you all for being here. So to start, I would really like to be able to cater this talk a little bit to the audience that I have in front of me, or in little squares in front of me. So if everyone could just quickly type into the chat their role and potentially what brings them here to this talk today. Great. So I'm seeing lots of social work, palliative chaplains. Jackie, are you able to keep up with this chat here? Chaplains, social work, legal advisor, helped write the law, palliative chaplain. Great. So, and nurses. So wonderful. So great. Thank you very much for sharing that. Health supervisors here as well. So hopefully I will give you some tips and tricks about the physician proxy process to help you in your daily work. So learning objectives today, we're going to start with a focus on the history of the development of the physician proxy law. And then we're going to go into the logistics of using the law. So the process mechanisms of when and how to use a physician proxy. We're then going to talk about why ethics is involved and how they're involved in this process. And then finally, we're going to conclude with talking about some of the ethical issues that have arisen over the past 6 years with the use of this law. So I do not have any financial disclosures. There are no financial benefits that come from the use of the physician proxy law, but I do have some disclosures. So I am a mother, I'm a doctor, I'm a teacher, I'm a leader, and I work to promote health equity. And I share those with you today because those are the lenses through which I approach my work as an ethicist and how I approach the topic of physician proxy that we're going to be talking about today. So I want to start with a poem. And this poem appeared in The Human Touch, which is an annual publication of poetry, of art, photography, and prose that comes from the work of people on Anschutz Medical Campus. So from students all the way up to attendings, nurses, social workers contribute their work to The Human Touch. And this poem was published several years ago by a nurse by the name of Colleen Birding. She now works at the VA Medical Center in St. Louis. And her poem is called Assignment. So here's how the story goes, at least on my side of the fence. You are assigned to me at the beginning. Name, room, diagnosis. You have a story on paper, that H&P. It's supposed to tell me everything medically significant about you, but sometimes it doesn't. It tells me that your leg is gone, or it tells me that your heart is weak. It tells me a story of your family, the mother who died of a stroke, the father who's still climbing hills at 80, the siblings who never see you. It's a story I have to remember, my map to taking care of you, at least to start. Sometimes the map starts in Topeka and you're already in Kansas City. I come in to see you, girded with my information, ready to meet the person I've only met on paper. In time, you stay with us. You are a usual suspect, a character I've seen before, over and over again. I learn your habits. 1 cup of ice, one third cup of ice, please. Cover my arm. Would you open my candy? I know you as more than a diagnosis on paper. You are at times neurotic, persnickety, downright funny. Eventually you go home and I just might see you on the street or when you come back to say hello. I remember your face, even if your name comes slowly. You talk to me and I remember more, that ice, that arm, that candy. And I know you're not a paper patient anymore. You're real. And I really like this poem. So as a doctor, this poem reminds me that everyone I treat has a story. As a teacher, it inspires me to help my learners find that story and help them to understand the value of that story. As a mother, it speaks to the value of human connection and the importance of family. And as an ethicist, I think this poem really highlights the importance of individual context, those individual factors that turn a patient from that paper patient on the H&P into a real human being. In this case, a persnickety, neurotic, downright funny human being. And in ethics, we often talk about our role of bringing all patients to the forefront, all voices to the forefront, but especially that patient voice. Anytime we perform an ethics consult, we try to understand as much as we can the psychosocial perspective of those patients. So who they are as an individual, how do they live within their community? What are their values? What are their goals? And how do those guide the care plan? And we see that in ethics as a way to move from that paper patient on the H&P into the real human being. But sometimes we know in medicine that it's really hard to hear that patient voice that turns people from that paper patient into an individual human being with values and goals, with unique beliefs and perspectives. And I think that our patients become vulnerable in medicine when we fail to move beyond the paper. So I'm curious, given all the roles that are represented here today, what are some of the instances that you've encountered where it's been difficult to learn about patient context, when it's been hard to hear that patient voice or hear their story? If you could just take a second and type into the chat, what are some circumstances where you haven't been able to find that individual patient? When they're afraid, when they don't want to open up, intubation, right? When they can't share their story, language, dementia, Alzheimer's patients, when John Doe was admitted to the ICU and there aren't family members, when they have dementia and can't share their stories. Exactly. So we've all encountered these scenarios. And when people don't have someone who knows them and who is able to speak for them when they can't speak for themselves, we run into real difficulties. So there's a lot of terms to describe these patients. Unbefriended actually has the most currency in the bioethics and the medical and the ethical literature, but I don't like that term. In my mind, it seems to stigmatize and in some ways demean these patients. So for this talk, I'm going to talk about these patients as unrepresented, and that's actually the language in our Colorado law as well. And just to make sure that we're all on the same page, unrepresented patients are those patients who, number one, lack decisional capacity to make the treatment decision at hand. Number two, do not have an advance directive that speaks to that scenario. And then number three, don't have family, friends, or legally appointed surrogate to assist in the medical decision-making process. So We've seen from that chat that we've all encountered these types of patients. This is a persistent, pervasive problem in healthcare and a huge challenge right now in ethics and in patients' rights. Some people say that caring for the unrepresented is one of the most difficult problems in medical decision-making, and others have said that it's the single greatest category of problems encountered in bioethics consultation. And one of the reasons that this is so difficult is that there is not a current standardized approach to decision-making for unrepresented patients on the national level. The American Geriatric Society has done a lot of work in this arena, and they've concluded that the state-to-state variability in approach to unrepresented patients has caused a lot of confusion for healthcare workers, and they've been able to show that in some narrative studies. This confusion has resulted in harms, including treatment delays and prolongation of potentially burdensome medical treatments for this really vulnerable population of patients. And this is not a small problem. So there are more than 70,000 unrepresented patients in the United States right now. The majority of these patients are thought to live in long-term care facilities or in the hospital. And there have been a couple of studies that have really tried to quantify these patients. It's more difficult than one would think. There's two main hospital studies. One of them showed that 16% of patients admitted to the ICU are unrepresented. And another study showed that 5% of patients who die in the ICU are unrepresented. There's also a key long-term care study that estimated that about 4% of patients living in the nursing home are unrepresented. So these are significant numbers, and these numbers continue to grow. I also want to remind us that while the elderly is the largest group of unrepresented patients, they aren't the only group who are adversely affected by the lack of a surrogate. And in terms of medical treatment, there are challenges to the amount of treatment these patients receive. In some cases, unrepresented patients are overtreated because they don't have an authorized surrogate. Sometimes physicians feel comfortable pursuing more aggressive or maximal medical intervention, whether or not it's medically or ethically warranted. Physicians may also have a fear of liability for failure to treat, or a philosophy of medicine that's just generally more interventionalist. So that results in overtreatment for this population. Now, this patient population can also be undertreated. There are physicians who refuse to provide treatment of any type without informed consent. We've also seen that important decisions may be postponed or altogether foregone when there isn't a decision maker. Here at university, we've actually had situations where physicians have waited for the patient's medical condition to deteriorate to the point that it becomes an emergency, and then they proceed with the emergency waiver, right, with implied consent, thereby circumventing the need for a surrogate decision maker. So this impacts broadly the treatment, both amount and timing, that the patients receive. And as many of us know, discharge also becomes really difficult with this population. Because there's no one to consent for discharge, the unrepresented patient often remains in the wrong healthcare setting, usually a hospital, for far too long. And this delay will lengthen their length of stay and also put them at higher risk for nosocomial or hospital-acquired infections or other adverse events. And physical harm isn't the only type of risk posed for these unrepresented. There is a huge affront to individual self-determination that comes with being unrepresented. Whether these patients are overtreated or undertreated, the unrepresented are often susceptible to treatment decisions that do not align with their own personal beliefs, morals, or values. And so before we launch into the Colorado specifics, I'd be amiss if I didn't spend a few minutes talking about ways to prevent a patient from becoming unrepresented in the first place. Because really, I think that prevention is the best strategy here. And I know, given the roles people have here, I know that I am preaching to the choir. But We need to make sure that we're engaging in earlier advanced care planning, right? That we're having these conversations earlier, that these conversations are happening in the outpatient setting long before a patient really needs to be hospitalized, right? We also need earlier identification of surrogates prior to need. It always amazes me when we encounter these patients, how many times they've engaged with the healthcare system prior to the event in which they're unrepresented, and there's no documentation of their values, no advance directive, and no documentation of their surrogates. So we really need to capitalize on those other opportunities to document this. And then finally, vigilant regular capacity evaluations are important so that if these patients do regain capacity, that we're able to recognize that and to hear their voice about who they want to make decisions on their behalf. So moving on, you may see some local celebrities on this slide. So we previously talked about the lack of a national standardized approach to the problem of these vulnerable unrepresented patients. In our state, there were decades of conversation about how to proceed. These conversations were happening within the Colorado healthcare ethics community. And so a coalition was ultimately formed. It was called the Colorado Collaborative for Unrepresented Patients. And it included some of the people you see here in this picture, a group of interested healthcare professionals. This collaborative launched a 5-year journey that ultimately resulted in the passage of a state statute addressing unrepresented patients. Now, I'm not going to go into the details here, but for anyone interested in how this came to be, there's a really great article by Deb Bennett Woods, who's here at the talk, Jean Abbott, and Jackie Glover, who describes how this process occurred. So ultimately, what happened was that the coalition led to the development of the Medical Decision-Making for Unrepresented Patients Law. It's a mouthful. And it's an amendment to the Colorado's proxy statute that was signed by Governor Hickenlooper, seen here, on May 18th, 2016. And this measure allows for an independent physician to act as a temporary proxy for patients who are unable to provide consent when there's no other proxy available. This new amendment received bipartisan support in the House and Senate and went into effect August 10th, 2016. So it's summarized here, and I want to highlight this very first paragraph, which says that the purpose of this amendment is to enable a proxy decision maker of last resort. That is, when no other interested party can be located and the patient lacks decisional capacity. So we're gonna take this and tease this apart a little bit. So let's talk about this first part, a proxy decision maker of last resort. So I really want to highlight that this is a decision maker of last resort. That means that we've exhausted all other possible avenues for decision making. It doesn't mean that we want to make a decision today and we haven't been able to contact everyone, so we're just going to move forward with a physician. It really means that reasonable efforts have occurred and that those reasonable efforts haven't yielded anyone able to make decisions for this patient. Now I put this picture of this sign here, right? This is a silly picture. It's quite obvious that the sidewalk ends even without that sign being there. But I think what's challenging with this law is that it's not as easy to identify when we've reached the end of an interested party search. And this is where we really have to rely on the expertise of our social workers to determine when reasonable efforts have occurred. This is in their wheelhouse. Here at university, our social workers have developed a tip sheet to help guide the search process to really ensure that reasonable efforts have taken place. And so the next part of that summary speaks to the lack of decisional capacity. And when we talk about decisional capacity or lack thereof, we want to make sure that we're talking about capacity for a specific decision. We really want to avoid doing global capacity assessments here because we know that capacity is rarely black or white. Capacity is shades of gray. Patients can have capacity for some decisions and not capacity for others. I actually recall a case here at university where the primary team felt really strongly that the patient had capacity for a code decision, but not for other medical treatment decisions. And that circumstance caused a lot of angst with the primary team. The code decision was a really important decision, and they struggled with the idea that the patient could make that decision for themselves but not others. And I think that happens because the code decision is a really value-laden decision. The values that guide that decision may be values that the patient has held their whole lives. And that might be different than their ability to understand and really rationalize about a complex medical decision or a proposed treatment at this time. So this is shades of gray and specific to a certain decision. The other point that I want to make is that decisional capacity forms the foundation of informed consent. And just as we wouldn't globally consent someone for every medical decision that might occur, we wouldn't do that with capacity. Instead, we want to make sure that we're carefully assessing a patient's capacity for each and every decision so that they can participate in informed consent as able. And that means that by extension, the use of an MD proxy should also be on a decision by decision basis. And then just a reminder that we want to be reassessing capacity regularly as the clinical situation changes so that we can acknowledge when the patient does have capacity and which decisions they have capacity to make. And then just a reminder of what we use here at Anschutz for capacity evaluation. If you type .decision into an Epic note, it will pull up this capacity evaluation. And this is to guide an individual's assessment of capacity. You can see here, again, the questions need to be specific to a medical decision. So their ability to understand their medical problem and their proposed treatments and alternatives. I think the best practice for capacity evaluation is not to necessarily go in with this form and go down the list, checking boxes, yes or no, but instead to engage in dialogue, potentially over several visits or encounters to really get at an understanding of the patient's understanding of their medical condition. I also really like to pull in the experience of our nurses and to get their sense of the patient's understanding of their medical condition and why they're in the hospital, because I do think that adds another layer of complexity and really helps paint this picture of a patient's decisional capacity for a specific decision. So let's move on and apply what we've talked about to a patient case. So this is the case of JG. He is a 68-year-old male. He has a history of a remote TBI and diabetes, and he's admitted to the hospital after being found down outside McDonald's. He has suffered frostbite injury to his feet, both of his feet, and he has an ulceration on the first 3 toes of his right foot. JG is stabilized and he started on broad spectrum IV antibiotics. The primary team wants an MRI to determine the extent of injury of his feet and to evaluate for osteomyelitis, so a deeper bone infection that would be treated potentially differently. And JG is grateful for the care and he's agreeable to this care plan. So psychosocial perspective on JG. Prior to this hospitalization, he was living in a mobile home. He didn't have heat or electricity. He's had several previous hospital admissions, but none that can be pulled up in Epic in the past 5 years. And he doesn't have any advanced directives documented. He says that he doesn't have any friends who knows him well. He's been to several shelters across the city, but none of them have friends or contacts. He's also been seen at Stout Street, but doesn't have contacts identified in that chart. And he says he's estranged from his family and hasn't been in contact with anyone for over 30 years. So what do you do next? The primary team wants to obtain an MRI. What are the next steps in taking care of this patient? So you would type into the chat, what would we do next? And yes, I agree. Jackie Glover is a rock star. I see that in the chat. All right, so I see utilize search tools to attempt to identify social supports. Great. So try to figure out interested parties. And so I think, and then determine capacity. Great. So I'd say yes, good, and obtain advance directives from the patient. So I think really, really good answers. I would say the first thing we need to do is make sure that the patient has capacity both to speak to his values and to consent for the MRI. So in this case, JG does not have capacity to consent for MRI, even though he is agreeable. And I think that's a really important point to make that we see happen poorly at times, is that patients who lack capacity to both consent and refuse. And so just because a patient is agreeable to the care plan doesn't actually mean that they have capacity to make that decision. So we want to make sure that we're assessing the patient's capacity. So by the law, it states that the attending physician should assess and properly document decisional capacity in the medical record according to the usual institutional processes. And again, here at Anschutz, that's using that .decision phrase. The law then goes on to say that we also need an independent clinician to do a capacity evaluation if it's not previously determined by the court. So we need 2 documented capacity assessments in the chart for this patient, specific to the decision for MRI. And then this reasonable efforts search. So these things can happen in parallel. And I've listed here some of the locations that our social workers have pulled together on our tip sheet. You can see it's really long. And I'm sure that there are many other places that they look as well. But the law states that the medical record should document which places have been searched and by whom. So we often ask our social workers to create a little bit of a summary note to synthesize the search that they have done for interested parties, so that we have a quick place to look to say that reasonable efforts have occurred. And then I'm going to call your attention to the second paragraph here. The ethics committee should be involved. And so this is the part of the law that really requires ethics involvement. So JG's team consults ethics for guidance, and they're put in an order here, and they're specifically asking for an MD proxy for the decision of an MRI. So ethics role is to review the situation, to ensure that the capacity evaluations have been completed and documented, and to ensure that reasonable efforts have been documented. And then ethics concurs with the plan to move forward with an MD proxy, because in this case, this really is a case for a proxy of last resort. So over the 6 years of doing this process here at university, this is the stage where things really slowed down. This is where the momentum halted. And it's because we struggle to identify physician proxies. So in the past, we'd ask for the primary teams to identify the proxy, and that was really burdensome to them. The primary teams didn't generally understand the process. They weren't sure who to ask, and they didn't really know how to describe to their colleagues what they were asking them to do. This created a lot of angst among the primary teams. When ethics tried to help with this process, it created a conflict of interest, because we have the next step requires us to concur with the proxy designation. It felt unethical to say, here is your proxy, and oh yes, we concur with them. So it really was a challenging part of the process. And so what we decided to do here at University Hospital, which is now becoming the process system-wide, is to use our physician advisors to assist in the identification of physician proxies. So physician advisors are people who are physicians who are focused on care delivery. So they often work in terms of overseeing case management and utilization review processes. They work on improving clinical documentation and coding. They work on care transitions. They monitor some of those metrics that are important to the hospital, length of stay, morbidity, and they work on improving workflows. They became a part of this process because there were major delays in care that happened when we were unable to quickly identify a physician proxy. So they acknowledged the downstream impacts of a delay in care or an increased length of stay and got involved in this process. So the steps that are going to happen is that once ethics is involved, ethics will communicate with the physician advisor that this is a case of proxy of last resort, and the physician advisor will identify an appropriate proxy for that patient. The ethics team will review and concur with the appointment of that proxy and document their consensus in the chart. And then the primary team physician will document the name of the physician proxy in the chart. Now, the physician advisors will generally not be accessing patient charts, but they may be asking for information specific to that patient to help identify the appropriate physician proxy. And they have a list of physician proxies from all the hospitals in our system. So these are people who have agreed to and already been trained in this role and are interested in serving in this capacity. So our physician advisors will reach out to these people and identify a willing and available physician proxy. We've also decided that the physician proxy doesn't need to be at the same institution, right? Just as families and other interested parties are not necessarily always local, we found that there is some benefit to using physicians at other hospitals. Some of our smaller hospitals have actually been really challenged in identifying a physician proxy who's not otherwise involved in the care of the patient. So otherwise having a conflict of interest. So by having a larger pool of available physician proxies, we are able to avoid some of those conflicts of interest that occur. So just a different view of the process. It starts up at the top left there with documentation of formal capacity evaluation by the primary team, documentation of interested party search by social work, an independent physician documenting capacity or lack thereof, and then moving down to identification of the MD proxy by the physician advisor. And I think what's so telling when you look at the process this way are how many players are involved in this process, right? This is a complicated process. It involves a lot of people doing a lot of things in parallel, and it's not something we do on a regular basis. So it can become really confusing. And so we've talked through the history. Now let's talk a little bit about the future of this process within UC Health. We're working to create a pathway for a physician proxy. So for those of you who aren't familiar with pathways, this is a screenshot of Epic, and there's a pathways button at the top that helps identify care plans. And you can see here, these are medical specific ones. So ACS or asthma. And it walks through the steps in caring for a patient with that diagnosis. There's also a really great advanced directive pathway. And what we're going to create here is a pathway starting with assessment of a patient's decisional capacity. And it goes all the way through physician proxy and splits off into guardianship as well. So we're going to pull some of the guardianship processes into this pathway. This pathway is just in the development stages right now. But hopefully we'll be up and running in the next several months, and we'll be sure to communicate that with all of you when it exists. So let's talk a little bit about who these mysterious physician proxies are, right? So the physician advisor has a list of these physician proxies. And again, these are people across the system who have been trained and want to serve in this role. We have physician proxies from different specialties and different hospitals. Some of them are palliative care docs, people who are accustomed to thinking about value-based decisions on a regular basis. We also have some surgeons who might be more stereotypically anyway, more interventionalist driven. We have some specialists. We have some gynecologists who might be more accustomed to taking care of a certain subset of patients. We have brand new physicians, and we have people nearing retirement. So our physician proxy pool is really quite varied. That said, it has been really difficult to recruit people to this role. This is a difficult job, right? It's a lot to ask someone to make a medical decision for someone that they don't know, who's often unable to verbalize their values. And many of these MD proxy decisions are end of life types of decisions, which further adds to the heaviness. And so I've spent some time recently talking to the physician proxies across the system to try to understand their motivations and how they make decisions in this role. And I want to share that with you. So I asked these proxies why they agreed to this role. Why did you become an MD proxy? And here are the things I was hearing. So I'm concerned about the well-being of the unbefriended. There's a patient in need, and I felt responsibility to do that. In patient care, I've encountered so many people who lack decision makers. I realized that having access to physician proxies is essential. I felt like in some small way, I'm making a big difference in someone's life. And it allows me to advocate for those unable to advocate for themselves. So this theme of advocacy, of helping someone, really comes through in the reasons that people have served in this role. So going back to JG, the physician advisor has identified an MD proxy. This is, again, somebody who is willing, who feels the value and importance of serving as an advocacy for JG. So what does ethics do at this point? Ethics has the role of writing, of documenting consensus on the designation of that proxy and on every decision that they make. So every decision that that MD proxy makes requires documentation by ethics about consensus of the decision as appropriate and consistent with facility policies. So documentation is key here. So in this case, the MD proxy is asked to consent for MRI for evaluation of underlying infection. The primary team now is worried that JG is also going to need sedation in order to tolerate the MRI because he's no longer agreeable to the care plan. So what factors should the MD proxy consider when making this decision? And so I asked our MD proxies, what factors do you consider when making these decisions? I'm going to read you some. So I have some insight into their decisions, insight from my family, community, literature, experience taking care of patients from the community. I try to factor in their lived experience and demographics. My approach is always to consider what's best for the patient given the clinical context and what we know of their values. In most cases, it's not possible to understand the patient's values, so I do my best to think through the decision as I would for a family member. And I try to think about the bigger picture beyond the decision being made that sometimes the team can't see. I try to get more perspective about who this patient is. I've called their nursing home, tried to talk to their previous healthcare providers. I need to know what he spent his time doing, what his personality was like. I need the non-medical perspective. I try not to let any class group designations influence my decision-making. I think it's important to go see the patient, even if they aren't able to talk to me. It helps me move from the medical model into considering this person as a human being. So really different approaches, really diverse approaches to decision-making for unrepresented patients. So back to the case of JG, the MD proxy consents to the MRI. The MRI, for those of you like me who don't read MRIs, does show osteomyelitis, and the team wants to proceed with surgery. So what do you do next? And in the interest of time, I will give you the answers as opposed to asking you. But we now need to assess JG's decisional capacity for surgery, right? So this is a different decision. We need to see if he has capacity to make this decision at this point in time. If he lacks decisional capacity, we need to do an independent capacity review. And if he lacks there, we'll reach out to the MD proxy regarding this specific decision. And then ethics will have to document consensus with the decision made by this physician proxy. So how has the role of physician proxy been for you? So something else I asked our physician proxies here at the university, or actually across the system. So people said, this is a hard but important role. These situations are always very tragic. I can see the positives. I have allowed patients to access prompt care and prevent suffering. It feels good to know the patient has an advocate. I stop and take a deep breath. This is a big responsibility. It's difficult because there's someone in need and I feel like I can't say no. I would describe the experience as deeply unsettling. You throw yourself into it and want to be there for the patient, but you don't want to imagine doing this for every patient. And these situations have challenged me ethically, morally, and emotionally. This is a hard role for our physicians. We've had physician proxies asked to be removed from any decision that is end of life, given the moral burden that it has placed on them. We've also had physician proxies do this a couple of times and then asked to be removed from the list because they need a break from the experience. So these are really taxing for everyone involved. And the other thing that I've heard over and over from these interviews was the value that the ethics team brings to these situations. Many people expressed how they felt extremely uncomfortable with the task, but felt better knowing that ethics was involved and that we were managing the process, ensuring that the proxy was really only doing those things that they were expected to do. And so I think it's important to go back to what we talked about at the beginning of the session about the vulnerability of these patients. These patients have a story. We know that, but sometimes they are unable to share that story or to use their story as a demonstration of autonomy, which makes them highly vulnerable. Now, I have a lot of respect for this law because I think it really does recognize the vulnerability of these patients. Now, I will also be the first to say that I think the way this law is written makes it really hard to navigate, and it's quite burdensome. But I think it does that because it sees the importance in protecting these really vulnerable people. And by involving the ethics committees as it does, I do think it offers a degree of protection for these vulnerable patients. We have to remember that the physician proxies themselves have their own stories, their own values, and the lens through which they see the world. Now, I started this talk by disclosing some of my lenses, and we all have those, right? It influences how we see the world. We often talk about using the best interest standard when making these decisions, but we also recognize that the decisions the MD proxies make are colored by their own values. I think it was really interesting in talking to these physician proxies. I found it fascinating to hear how they considered patient context when making decisions. So one proxy talked about how certain backgrounds often make people less likely to trust the healthcare system and therefore more likely to want aggressive intervention. And so they factor that in. Another talked about asking the team whether the patient chart had an identified religion so that they could get a sense of the patient's values. So really trying to get at that patient context. And while I think all those contextual components are important, because these are the aspects that really change from that paper patient into that real human being, there's obviously a risk of intrinsic bias or stereotyping that can occur when someone is inferring context or making decisions about someone they don't know. One proxy actually spoke about trying to avoid knowing these aspects of a patient's life, those demographics like race and religion, so that they were more objective in making decisions. So there's a lot of questions here about how this is best done. And I don't have answers to any of these questions. I look forward to continuing to move forward together and to learn more about this process each time we do it. And so in conclusion, I hope that we have effectively streamlined the process of using a physician proxy. We've made it clearer, easier, and more efficient using the physician advisors as the identifiers. That said, we need to continue to grapple with some of the ethical challenges related to the use of a physician proxy. Things like how much context should be considered? Is there value in actually visualizing, seeing the patient? And have we removed that potential if we're using a proxy in Colorado Springs for a patient in Fort Collins? Do different types of physician proxies make different decisions based on their specialties? Do palliative care docs make different decisions than surgeons or than OB-GYNs? And should we be trying to align the patient's clinical context, the decision at hand with the MD Proxy specialty? Or are we better served by malaligning those? So I'm leaving you with all of these questions. I want to thank you all for your work in this process and for continuing to do the good work to try to protect these vulnerable patients. I really do think we've done really strong work here for this vulnerable population. And I think we've been really thoughtful about how to approach the medical decisions that impact their care.
Thank you so much, Dr. Ferrari. We have 6 questions in the chat, and I'm going to group them, the first 3 and the latter 3. The first 3, Melanie says, oh, these 2 capacity evaluations, that's new. It's not in our policy. Do you have to use it all the time or just in specific interest? Casey wants to know about end of life. And how often do you do it in the most difficult end of life, hydration and nutrition? And from his experience, people find it very hard to find a second physician to speak to the prognosis. And the third question, you might try to do the third question first. It's easy. Can you use physician proxies from outside the university system? From another hospital?
Okay, so good, really good questions. None of those are easy, Jackie. So, so the one thing to remember about physician proxies is that they cannot access the medical chart, right? They can't look at the chart as a physician. None of these proxies should be in Epic reviewing the patient case. And so it is possible to use physicians outside of university hospital for this role. I will say my hope is that we've created a process here by which we have people trained and confident with this role that you wouldn't necessarily need to go outside of UC Health unless you felt there was some reason to do so, but it can be done. Like I said, these people that we've identified have all been trained, so they won't just automatically jump to the chart and start looking up the patient context that way. Although we've seen that happen with people who are less skilled or have had less experience with this role. So in terms of the capacity evaluation, so sorry, I haven't actually reviewed our hospital policy, and if it's not in there, we should work on revising it to make sure it does reflect the law. But the law does require 2, so 1 from the primary team and an independent capacity evaluation for each and every decision that's being made. To speak to the end of life decisions, those also require an independent physician to assess the prognosis of the patient. So that's an extra layer. Again, I have to remind myself it's an extra layer of protection for the patient when we're talking about these end of life decisions that we're making. So 2 capacity evaluations, prognosis from the primary team, and then an independent physician to review the situation. Those people can access the patient chart and then to document an independent prognosis. And we have used these MD proxies for end of life decisions. We've used them for trach and peg.
Oh yeah, hi.
We've used them for transition to a comfort care approach. So we absolutely have used them for those end of life situations. And again, just making sure that we have that prognosis also documented in the chart.
Perfect.
Thank you. David, can you please mute? We're hearing you.
Sounds great. Thank you so much.
David, mute, please. Kristen, 3 other questions. One has to do with the cumbersome nature of this and speaking to someone who.
Thank you.
David, please mute.
I know.
I think I can mute him. I got him.
Oh,
muted.
perfect. Thank you.
Got the
Christina.
power.
So this is designed to be cumbersome and
Yes.
not on purpose, and not agile on purpose. Just to speak to the legislature, they didn't trust physicians. And they wanted the law to change it to make the ethics committee make the decisions, and that's not the role of an ethics committee. So it was a compromise between another physician with concurrence from the ethics committee, but it is cumbersome.
Yes.
And have you appointed a point person for this cumbersome process? And what do the physician advisors think of this? Do you have any feedback? And
Yeah,
okay.
good question. So the physician advisors are actually thrilled with this process. Again, they came to this because primary teams were really frustrated with being told that they had to find a physician proxy, and they would often reach out to the physician advisors for help and guidance. So our physician advisors were getting pulled in and didn't really have a lot of knowledge or expertise about the law to know what to do next. So they are actually really thrilled that there now exists a clear process. They haven't seen this as a burden. Again, I think they recognize that the more efficient and streamlined we can make this process, the better the outcomes for the patient down the road. And the things that physician advisors really care about are things like length of stay and delays of care, which occur if we don't do this well. So generally, the physician advisor pool has been really open and have really embraced their role in this. In terms of how burdensome it is, I agree 100%. This is a challenge, right? And I think the burden comes from the different layers that need to be performed, the documentation that has to happen, and then all the involved players, right? It's not just the primary team flowing through a process. It's multiple different teams and specialties doing their work in parallel and documenting it in an efficient way so that the process can continue to move forward. And so my hope is that while I'm not going to be able to change the burdensome nature of the way the law is written, that we can make our process more efficient and help people understand where we are in the process by having that pathway that anyone can access and see in real time. And again, like Jackie said, I have to remind myself every time I'm using a physician proxy law and engaged in it from an ethics standpoint, that it's written this way to help protect these vulnerable people. That's why I thought it was really important to talk about the vulnerability of these patients at the beginning, because if we're not careful, there is a real risk of doing things that may not align with what the patient would want or what is necessarily in the patient's best interest. And so I think the layer of protection that ethics committees add to this process is really essential.
And Kristen and Melanie have found our policy, and it only says one capacity evaluation.
Well, thank you, Melanie. And I think we have work to do.
Yeah, and Julie Swaney has one of the most difficult questions. What if the patient wants to ask for one, or the family doesn't want to be involved, and then they're not unrepresented? In one case, the patient is asking for it. In the other case, there is family that doesn't want to be involved.
So good questions. And I don't have great answers for you. This is something that we've started to talk about actually here at university. Can a patient refuse an interested party search? A patient with capacity, can they say, I don't want an interested party search. I don't want you to engage with my family or friends. I want a physician proxy. And there's clearly a legal component to that we're just starting those dialogues with our legal representation here. There's clearly a legal component. I guess where I would go with that is that if the patient has capacity to make that request, that we should really be capitalizing on understanding that patient's values and documenting that in the chart, right? Clearly documenting advance directives. What would the patient want in all of these various situations? What are their values that they want us to use in guiding those healthcare decisions that they will make in the future. And so again, it goes to this idea of prevention, as much as we can, really documenting when the patient's able to tell us their values, their goals, their beliefs, that we're capturing those. I think that the question of kind of family requested MD proxy also has a legal component that I don't know the answer to. But again, I think the family can offer that insight, whether they're willing to serve as surrogate decision makers or not. Hopefully they're able to offer some insight about who this person is as an individual, and what matters to them, so that if we do have to use a physician proxy, that there's some values to guide that decision making.
And Julie is asking about when will their physician advisors get trained? They don't seem to know about this role. So for your information, I guess there's questions about how widely the physician advisors know their
So they have
responsibilities.
all been trained in this. But again, this is one of those things that doesn't happen with a lot of regularity. And so it is something that will need continued reinforcement and continued reminders. And again, I'm hopeful that the pathway will streamline all of this and make this easier for people to know their roles in the process.
Thank you so much, Kristen. And in the chat are the 2 articles that are describing the law and guidelines. And also in the chat is, the current policy. And hopefully everyone else will come back to Ethics Grand Rounds on March 10th to talk about when patients have made suicide attempts and request medical aid in dying. So thank you so much, Dr. Furfari. And this is recorded and available to people on coloradobioethics.org.
Thank you very much, Dr. Furfari and Jackie, and all of you for joining us, and hope to see you in a month on March 10th for another compelling Ethics Grand Rounds.